Welcome, everyone, to this episode of a special 5-part series of the Sunflower Palliative Care podcast. This is a collaboration between the Sunflower Children's Network and Canada's Pediatric Palliative Care Alliance. The series explores issues for equity-deserving groups in palliative care, including vulnerably housed and homeless communities, Indigenous communities, disabled communities, diverse sociolinguistic communities, and Two-Spirit LGBTQ+ communities. I'm one of your hosts, Rachel Neufeld, nurse practitioner with Canuck Place Children's Hospice in Vancouver, Canada. I have the pleasure of speaking with Dr. Naheed Dosani, a palliative care physician and health justice activist who is dedicated to advancing equitable access to healthcare for people experiencing structural vulnerabilities like poverty and homelessness. These efforts include founding and leading the Palliative Education and Care for the Homeless, or PEACH program, at the Inner City Health Associates in downtown Toronto, Canada. Serving as the medical director of Kensington Hospice for Kensington Health, a health equity expert advisor at the Canadian Partnership Against Cancer, and as a palliative care physician at St. Michael's Hospital with Unity Health Toronto. Thank you so much for being here, Naheed. I really appreciate you taking the time to talk to us about this topic.
Thanks for having me on the podcast. Really appreciate it, Rachel.
I wonder if you can start by telling us a little bit about your journey into palliative care, and particularly working with this structurally vulnerable persons community.
Yeah, for sure. My journey into palliative care started long before medical school. I was born and raised in Scarborough, Ontario, just outside Toronto, which is now part of Toronto. As a son of two refugees, growing up, I saw how social factors like poverty, systemic racism, access to housing, and the social determinants really shape healthcare outcomes. That understanding drew me into palliative care, which is truly a community-driven and a community-minded area of healthcare. But how that really happened was during my residency training in Toronto, I had an experience that changed everything. I met a man who was experiencing homelessness with advanced cancer. His name was Terry. His pain was severe. But after being seen in the emergency department, he was turned away and discharged back onto the street because there was no system in place for him to get ongoing palliative care. It really forced me to ask a lot of questions about who gets access to palliative care and who's left behind. Since that time, I've worked to found the PEACH program, Palliative Education and Care for the Homeless. PEACH is a mobile street and shelter-based palliative care program that aims to provide care and bring care to people on the streets, in shelters, encampments, or even under bridges. Over the past decade, our team has focused on making palliative care more accessible and trauma-informed. I also founded the Radical Love Equity-Oriented Hospice Palliative Care Program at Kensington Hospice in downtown Toronto to ensure low barrier access to hospice care for people who experience structural vulnerabilities. And beyond direct care, I co-chair a national initiative called Improving Equity and Access to Palliative Care, which is funding 23 projects across Canada to develop equity-oriented models of care for structurally vulnerable people. Now, I do want to say, Rachel, I'm not a pediatric palliative care specialist, but what I do know is that inequities in care affect children just as they do adults. And whether it's a child from a racialized community facing systemic barriers or a family struggling to navigate the health system, a lot of the patterns of exclusion are similar. And that's why I'm so excited for this conversation. Thanks again for having me here.
Wow, that is quite a bit that you have managed to accomplish, and clearly supporting your community. Also, it sounds like a project of love and passion from where you've come from. So I really appreciate you sharing sort of where this all came from and how you ended up doing this work. And as you say, not a pediatric palliative provider, but as you're encountering these folks, families, I'm sure too, that are vulnerably housed, how do you think the challenges differ for children in these communities that you work with? What do you think are maybe some of the unique considerations that would be involved in their care? Maybe it's children needing the care themselves, but maybe it's children of their family that need that care.
Yeah, such an important question. And again, want to acknowledge that while my primary experience is in adult palliative care, the challenges I've seen in marginalized communities, things like poverty, systemic racism, and structural inequities, don't disappear when the patient is a child. In fact, they often become even more complex because we're now talking about entire families navigating those barriers, not just individuals. One major difference is that when a child has a serious illness, the entire family is affected, not just emotionally, but structurally. I mean, Rachel, you've seen it, you've heard about it too. Many families in structurally marginalized communities already face barriers to healthcare, and when a child has complex needs, those challenges often multiply. For example, parents who have a sick child may struggle to take time off work for appointments or lack access to transportation. Many don't have paid leave, and losing income to care for a sick child can actually push entire families further into poverty. When I think a little bit about the considerations for this population, I think one of the biggest ones is trust. Many people who have been marginalized in our communities have had bad experiences with the health systems, sometimes across many generations, actually. There can be fear that accepting a palliative approach to care just means giving up or that it would lead to some other bad outcomes. This is especially true for racialized communities who have often have a deep history of mistrust due to medical racism and system issues. Culturally responsive care is an essential part of this too, and culturally safe care is a big part of it. Especially when families come from different backgrounds, we can't make assumptions that what we're going to be talking about, pain management, end of life rituals, or even the way we talk about spiritual care, will be heard in the same way. Even though my work has been primarily with adults, I think a lot of the principles of equity oriented palliative care span across all ages and certainly can support children. I think we need to, as a palliative care community, focus on proactive outreach rather than waiting for people to find us. We need to go out to the community and find them, whether working with schools, faith communities, or grassroots organizations. And finally, I always say this to people who are proponents of palliative care and believe in palliative care, that if we want to address social change, we have to invest in policy change. Remember that the structural barriers that families are facing, like lack of paid sick leave, or difficulty accessing culturally safe care or inadequate supports, won't be solved with just clinical care. We need to drive systemic solutions. We need to be advocates. We need to be part of these conversations and using these narratives and talking about these stories with consent and support, of course, from patients and families, but really see advocacy as part of the healthcare work that we do each and every day. The work we do in equity-oriented palliative care is just so important. It has to be seen as part of the work.
Yeah, I totally agree. Some of your comments have made me think a lot about some of the families here in Canada that have, on the verge of poverty or living in poverty or living in, very vulnerable housing. And I also think about the impact to their decision making that has too. And so I appreciate your comment around some of the trust of the healthcare system in terms of the decisions families have to make. And I also know that in my work with Two Worlds, when we work globally, financial consideration of accepting or taking treatment as a whole can be a major barrier to children receiving certain parts of their care. I think that that's really important here in Canada. And then also, I just make these comments in my own head too around some of the work that we do internationally, where parents need to know that they're being the best parents that they can be. And when finances and these vulnerabilities are impacting their decision making, that they may have made other decisions that has major impact on what this care is going to be like for a child. I think there's a lot of complexity and layers to this topic for sure. And I appreciate that it is more than the clinical care that you or I are doing as medical providers. And it's so much more than that on multiple levels of advocacy too in our communities, a lot of the program you're working on, and then bigger and government wide as well.
Absolutely. 100%.
What role does housing instability or a lack of this cultural awareness and culture sensitivity play in the physical and emotional health of these people that are receiving palliative care?
Yeah, access to housing and culturally safe care aren't just side issues in palliative care. They're central to whether or not someone actually receives high quality, compassionate care at the end of life. When it comes to housing, I mean, when someone experiences housing instability or homelessness, it's like dominoes. Every other aspect of their healthcare is affected. And it's obvious that this is true in palliative care. Managing symptoms like pain, nausea, or shortness of breath becomes so much harder when someone is living on the street or in a shelter. Think about keeping medications safe, storing essential medical supplies, or just having space to rest. Like these are real issues. It's also about dignity, the ability to make choices about how and where people spend their final days, and is something that many of us actually take for granted. And what we've learned through PEACH, our palliative outreach program for people experiencing homelessness, is that palliative care can't just exist within the walls of hospitals or hospices. It needs to meet people where they're at. And of course, I mean that physically on the streets and in shelters, but I also mean that emotionally and spiritually. And on that point, just because you brought up the topic of culturally safe care, it's important to recognize that a person's cultural background does shape how they understand illness, death, and grief. And when palliative care providers when we don't acknowledge or respect that, it can lead to mistrust, miscommunication, and even just the outright rejection of care. So, for example, some cultures have really strong beliefs about discussing death. And in certain traditions, openly talking about prognosis may be seen as inviting death in the home, which means our typical approach to advanced care planning might not work. So, we really need to adapt. The reality is, culturally safe care isn't just about having all the answers. It's about co creating our care plans, co creating the kind of care we want to provide and support to honor the values, beliefs, and traditions of the people we serve. And so I truly believe that housing and cultural safety are so central to the human dignity we hope to derive when delivering palliative care.
Yeah, I absolutely agree that a person's culture is their own. So there are some cultures that you grow up with that you have learned as a child, and then there are parts of your culture as a person based on who you are in your world at that time, and that can be impacted by being vulnerably housed or having, issues with your housing that absolutely play a role in how you're engaging with healthcare system, the trust or the lack thereof in the kind of care that wants to be provided. Even with your outreach program, I could imagine that that's a challenge. And I think about this idea of this culturally safe practice in terms of how we approach pediatric palliative care from the PEST model, which looks at physical and emotional, spiritual, social care of that person. So that social impact on how that child is receiving care is paramount. And so I think this ties in, again, recognizing that a lot of your work is maybe with autonomous adults that get to talk about this for themselves. But for the pediatric side of things, we have to also incorporate the care of the adults as they care for a child as well from that really safe place. I'm curious, in your experience then, how can a healthcare system and us, its workers, better integrate supports and understanding for these vulnerably housed communities, and particularly when it comes to providing palliative care?
Yeah, at the outset, I'm going to say this is a really important question because the raw reality is that our health system, particularly in palliative care, was never designed with people who experience homelessness and poverty and other structural vulnerabilities in mind. The default assumption is often that patients have stable housing, access to transportation, and support systems. But when those things are missing, people fall through the cracks. So, one of the ways that we could better integrate supports for people experiencing homelessness is really to shift how and where care is provided. We talked a little bit about this, but I think the Peach experience has shown us that when we take our care outside of the walls of clinics and hospitals, we're mobile, we're where people are, we're grassroots, we're community minded, we can better connect with people. Second, I think in the spirit of specialization, we've almost created a system that has added barriers in some places, particularly in palliative care. So we probably need to create lower barrier access to hospice and palliative care. Many health facilities or palliative care programs have strict admission criteria that exclude people who have, mental illness, people who don't have a fixed address or don't have, someone to support them. Through our program at Kensington Hospice, the Radical Love Equity Oriented Hospice Palliative Care Program, we've proven that you can take a mainstream hospice that serves a community and you can actually create low threshold, low barrier care just right there. The third thing I think we need to do is recognize that palliative care is not just medical care, it's social care. It's about caring about the housing, food insecurity. It's about caring about the social determinants of health and all the supports that go with that good care. Also, we as health workers, as individuals, healthcare workers, sometimes say, why won't this person engage with care? When in reality, we can also be asking, what barriers are in their way or how can we remove them? A lot of the time, it's not about a reluctance to receive care. It's about a system that doesn't accommodate a person's lived reality. And so with that, I think trust is just so huge, right? when we're able to build trust with the people we serve, we're able to go that much farther and do that much more. So, yeah, I think organizations can do this work. I think our governments can do this work. And I think we as health workers can be doing this work as well.
Yeah, thanks. And it also makes me think about one of the barriers that people can struggle with in accessing palliative care is what you mentioned earlier was advanced care planning. And if there are already trust issues or decision-making concerns and we require them to have some sort of goals of care established before accessing palliative care, that can also be problematic. And what I'm hearing you say is we have to meet people where they are so
Yeah.
that we can continue to work on shared decision making and shared care that maybe helps them do some advanced care planning eventually. But that also is another barrier that I was thinking about as you were mentioning it earlier, that not everybody's going to be ready to talk about that right away, but they still deserve to get the really good care. I also think about too that providing care for someone whose health is declining, the social determinants of health are just 10 times more important because of possibly declining ability to care for themselves. And when you're caring for pediatrics with serious illness, that often includes significant need for other medical devices and equipment that can be extremely difficult in either poor housing or lack thereof. So, re-looking at barriers to accessing palliative care and what does palliative care actually mean in terms of the trajectory in which we'll follow a patient, I think is really important to rethink and look at again.
100%. I totally agree with you, Rachel.
How do you think that healthcare system and its workers like us can better integrate this cultural humility and safety and awareness, reflecting on the diversity of our patients when it comes to palliative care?
Yeah, first of all, these concepts cannot just be checkboxes. They need to be meaningful, they need to be compassionate, and they need to be effective. If care isn't provided in a way that reflects a person's values and beliefs and tradition, it risks feeling impersonal or even at times harmful. And so one of the biggest shifts that I think we need to make is going from this cultural competency concept to a cultural humility concept to actually cultural safety. Competency implies there's a point where we fully understand another person's culture, but that's really not realistic. Instead, cultural humility means acknowledging that we're always learning, always listening, and always adapting based on what matters most to a person and their family. And cultural safety just takes it, even further. At a systems level, it means really designing palliative care services that actively reflect and respect the diversity of the communities we serve. It's about hiring diverse workforces, embedding interpreter services as a standard of care, and ensuring that there are policies that allow for flexibility in care delivery. Your example about advanced care planning is a really good one. We have a very westernized approach to how we talk about advanced care planning and do advanced care planning, and it doesn't always jive with the people in front of us. And go figure, it's because the people in front of us are diverse and come from different backgrounds. So we need to think about a lot of that. As a researcher, I've done some work looking at, particularly the perceptions of people who are in need of palliative care who come from South Asian backgrounds. And trust is such a huge thing, and the involvement of multi-generational families in decisions, which is not always the case in our westernized approach to advanced care planning. It comes up a lot. Ultimately, we as palliative care advocates and providers who are promoting cultural safety, when we go back, after this conversation is over, we go back to our local communities, we're going to have to be comfortable with challenging the structures around us and the policies that exist that create barriers to care. And I think once we do that, when we do that, we can probably underscore the respect and dignity that everyone deserves because it's so foundational to what culturally safe care really can look like.
Thank you. It makes me think again of the work that we do at Two Worlds and teaching in South Asia. Specifically, there's a lot of concepts that we teach from our Western perspective and then have to say, now, how's that landing in your language, your culture, your perspective? How do we create similar concepts of care, but that fit with how somebody maybe communicates them in a different way? And I think that that also then specifically includes how someone is communicating with us in a vulnerable place of being vulnerably housed or having difficulty with their housing situation, that and how that impacts how they're communicating with us too. Do they even have access to phones and emails where their appointments are being booked, or how are we even communicating with them in a way that makes sense so that we can meet them where they are? There's clearly a lot of layers here, and
A
I think
lot.
Yeah, and I really appreciate the comment around cultural competency because I agree. I don't think any of us will ever be culturally competent because that feels like an endpoint. Whereas we can continue to strive towards humility and then possibly within some safety that we're addressing some of these issues. And as we know, we've addressed this a couple of times already today, but our podcast does focus on pediatric palliative care. And I would love to hear from you, what lessons have you learned from working in the adult population in palliative care that you think can be applied to children and families that are in similar situations?
Yeah, it's a really great question, and I've certainly seen how the challenges that marginalized adults face in my practice, whether it's housing instability, poverty, or inequities in access to care. But I've also seen how they impact children and families, and the lessons we've learned in doing this equity oriented palliative care thing can absolutely inform how we might approach pediatric palliative care and to be equity oriented there too. One of the biggest lessons is that palliative care has to meet people where they are. In the adult populations, we've seen the power of bringing care outside of hospitals into shelters, encampments, homes, and community spaces. And I think the same principles apply to pediatrics. Many families facing structural barriers can't come to a tertiary care center. If we want to provide equitable pediatric palliative care, we need to be proactive and out there, ensuring families have access to care in the spaces that are familiar to them. Another key lesson is the importance of trust. Many families, especially those racialized, lower income backgrounds, for example, have a deep mistrust of the health system, often for really good reasons, actually. They might worry about engaging with you. They might even think that palliative care is giving up, or it might trigger some really negative feelings in their child. In adult palliative care, we've learned that trust isn't built overnight. So there's always that famous quote, move at the speed of trust. It requires consistency, humility, and a deep commitment to listening. The same is true in pediatric palliative care. Families need to feel heard, supported, and not judged or pressured into care decisions they may not align with. We've also learned that cultural safety, like you've heard it throughout this discussion woven through, it's not just a nice to have, it's essential and critical to palliative care. So we will never serve culturally and linguistically diverse communities if we're not culturally safe. And I think the last one is that through the adult palliative care work and the equity oriented work that we've done on multiple levels, developing clinical models, advocacy, research, and education, we've seen that it can't just be about the medical care anymore. We have to transcend into advocacy. If families are struggling to access palliative care because of systemic barriers, then it's part of our job as palliative care providers to address those barriers. And so I have no doubt the pediatric palliative care community is already doing a lot of this incredible work. I certainly see that from the adult work, the impact we've had just over the last 10 years in sort of the equity space in palliative care. And I'm super excited to see how many of my colleagues across Canada will continue to do this work in the pediatric space.
Yeah, thank you very much. I think that trust piece is just so profound and a reason that I think is a big benefit of pediatric palliative care being brought in very early in a child's diagnosis, where we can then build rapport and trust with the family over time, perhaps if there is time with the child. And I think there is a growing recognition of meeting families where they are in terms of growing these programs beyond the walls of the big children's hospital, meeting them in their homes and in their communities. And if transportation is an issue, can we go to them? Things like that. And I think that their trust in us allows us to make recommendations or express our worries with them in a way that will be heard so that we can continue a shared decision making where families can feel like their decisions about their children are loving and that we will support their decision making. I think that that's pretty profound. Looking ahead, what are some of your hopes for the future? Palliative care
Honestly,
for equity deserving communities. How do you see the role of us evolving in that space?
I mean, I think this is really it, right? This is arguably the most important question about like where are we going with this work? In reality, I hope that we can move from an equality-based health system or palliative care system where people get the same things to be happy and healthy, to an equity-based palliative care system where people get what they need to be happy and healthy, to a justice-based palliative care system where people get the resources they want, when they want, how they want, and get to choose the kinds of care and supports that they get that can make them happy. albeit, palliative care is often under tragic circumstances, the point still stands, right? And so I'm dreaming of that shift, really. I'm really hoping that we're able to do that. I'm hoping for a palliative care system that is more proactive, more community based, that has specialized funding to acknowledge people who don't plug into this normative system we've developed, because there's a lot of people who fall into that category. I'm also hoping that we can create structural changes and remove barriers to care. Things like expanding home based palliative care services, creating hospice care in non-traditional spaces that we might not even consider to be a hospice right now, but maybe in the future, and making them more embedded in the community by way of space, but also in cultural spaces, for example. I hope we can see more investments in outreach-based models and more supports for the caregivers, please. More supports for families and caregivers who lots of research and a growing body of knowledge continue to show that caregivers and family members are facing significant issues when it comes to how much they're investing in the care and then the financial disparities they face after that, not to mention the emotional issues and the emotional toll that this takes. My hope for conversations like this, Rachel, and I can see like your passion too, is that being in the space and having discussions like this is important and it is evolving. And I personally engage in conversations like this to hope that someone listening to this who believes in palliative care, whether it be pediatric or adult or all of it, becomes an ally with us and then goes back to their home community or wherever they are, and then they become an advocate and eventually they become change makers. When we see this advocacy as part of the palliative care work, this commitment to dignity, justice, and making sure that no one is forgotten, anything's possible. So my call to action is this, for all your listeners: let's stop treating equity as an extra in palliative care. This isn't a side project. This is not a special initiative. It is the work. And if we truly believe in the principles of palliative care, which are compassion, dignity, and comfort, then we have to commit to ensuring that every person, no matter their circumstance, has that access to that kind of care. This is the future of palliative care, and I'm quite convinced it's one that we can all help build together.
Thank you so much. I can clearly hear so much passion in the work that you do. And I think that there are a lot of things that we've talked about today that do really play into pediatric palliative care as well. And this work is something that we have to also be willing to be flexible with. And I think one of the things that I love about palliative providers as a whole is that we are generally really flexible people and we will move mountains to make things happen for people because we're so focused on the reduction of suffering and the improvement of quality of life and comfort and all those things. So if we can be so powerful in making certain things happen for our patients who are maybe reaching the end of their life, surely we can also think a little bit more flexibly in how we reach these people and how we provide the care for them. So I think that there's a lot of ways that palliative providers and programs function that if we just tweak them a little bit, they can really, really hone in on this particular topic and make it a priority. So thank you so much, Dr. Naheed Dosani, for taking the time to talk with us today. Anything that you want to say that we haven't talked about yet?
No, I mean, I just want to really thank you, Rachel, and the entire team for this project, for doing this podcast, and for creating spaces for conversations like this. There aren't enough spaces like this, and thanks for doing your part. It means the world to me, and I know it's going to make a huge difference. Thanks for having me on, Rachel.
Thank you for listening to this episode of the Sunflower Palliative Care Podcast. This unique series on equity in children's palliative care is produced in collaboration with Canada's Pediatric Palliative Care Alliance, with support from Health Canada. We look forward to sharing more from this 5-part series. To learn more about the Alliance, please visit pediatricpalliativecare.ca. The Sunflower Podcast grew from the seed of an idea as we talked with our colleagues in the Sunflower Children's Network. This network is an initiative of Two Worlds Cancer Collaboration, focusing on children's palliative care. We hope to build a world where no child suffers from serious health-related issues. To learn more, please visit twoworldscancer.ca. Thanks so much for listening, and we look forward to sharing the next episode of this series with you.